Good morning. I'm Lauren Holt. I'm one of the fourth-year residents at Emory University, Department of OBGYN, applying for maternal fetal medicine specialty this year. And I would love to hear a little bit about yourself and tell us about your work.
So I'm Nyirjesy. I'm a professor at Thomas Jefferson University in Philadelphia, and I co-direct a program called the Jefferson Vulvovaginal Health Center, where we see women with chronic and complicated vulvovaginal infections and a lot of vulvar skin disorders. I did an ID fellowship at Temple University, which I finished in 1992, and then started working with women with chronic vaginal problems in 1991. Where established a program called the Temple University Vaginitis Center, and then I've been in Philadelphia doing similar work, seeing the same sorts of patients for 30 plus years at this point. So.
That sounds like an awesome clinic, and your patients are very lucky to have you up there.
Thank you.
So today we wanted to talk about your article, which is fluconazole-resistant Candida Albicans Vaginal Infections at a Referral Center treated with boric acid. So kind of just to start, I wanted to hear kind of a little bit about what brought you to the interest in this topic and kind of what prompted this study.
Sure. So one of the things that I noticed early on when I was seeing women with chronic vaginal problems is that everybody would come in telling me they had recurrent yeast infections. By the time they got to me, only 20% actually had recurrent yeast infections. And in 1992, I spent a week with Jack Sobel in Detroit, and he taught me first of all how to correctly diagnose yeast infections, and then he showed me a very simple treatment algorithm for recurrent Candida albicans infections, which was to give them 3 pills of fluconazole 3 days apart. Actually the 150 milligram dose didn't exist, so it's 200 milligrams, and then treat them with 200 milligrams once a week for the next 6 months. That protocol, variations on that protocol became part of the CDC guidelines, the ACOG guidelines, and I've been using protocol variations of that protocol for decades. And for Candida albicans infections, while patients are on treatment, it's been highly effective. It's like so easy. For some reason, nobody puts patients on maintenance fluconazole, even though the placebo-controlled study got published in 2004. It's a super easy protocol. But what we've noticed is that that protocol doesn't work anymore, or there's some people where it doesn't work anymore, and that's where this study came up.
And so you kind of led me into my next question when you said you learned how to correctly diagnose yeast infection. So for all those out there, how do you correctly diagnose like a resistant or recurrent?
Well, so recurrence, first of all, is patient just saying she's had a lot of episodes in the past. Optimally, she's had some sort of hard data to show that she really had yeast, either a positive culture or positive PCR test. And then optimally, they come in when they're symptomatic, they haven't taken any treatment, and you get a positive yeast culture. And maybe the one point I should emphasize is the focus of this paper was Candida albicans infections. We see a lot of non-albicans yeast. The trend has been to do PCR testing for yeast, which is really good for Candida albicans with the ones that are FDA cleared, but there are certain types of yeast that they don't even look for. And so we still think that yeast culture is the correct test to do for diagnosis.
And what specific risk factors for resistance did you guys identify within your study, or have you identified?
Well, so for resistance, so first of all, maybe just to step back, most people with recurrent Candida albicans infections are not resistant. They, some patients, over the years I've had patients almost refuse to take fluconazole because they say it's not going to work. It always came back, but the trick is the length of treatment, which makes a huge difference. So resistance here we defined clinically, so patients who'd be on maintenance therapy, they still had Candida albicans infections and were symptomatic from it, or patients who had recently taken a treatment and still had it. And then the third is some patients were getting susceptibility testing done and had MICs that showed that they had a resistant isolate. And then in terms of the risk factors, being on maintenance was one of them. And you looked at the paper also, I forget what the other risk factors were.
I guess more specifically, like, were there any other medical conditions? Like, do you guys look at like anything like diabetes or other things like resistance?
Yeah, I think in our paper that they weren't risk factors, if I recall correctly. Yeah, and most women with recurrent yeast, at least half of them, it's idiopathic. They're normal, healthy people who don't have anything obvious. They don't even take antibiotics that often. They just, once they get a yeast infection, it just becomes this ongoing pattern.
What were the findings of your paper? What are things you want to make sure that the clinicians know about?
So with Candida albicans infections, fluconazole resistance has been very low, very low. In this study, and I think we had about 900 patients who had a positive Candida albicans swab, 7% had resistance to fluconazole.
Yeah.
That is a major change from what I was seeing about 10 years ago. And so for some people, the go-to option is no longer a go-to option.
What do you think explains that difference that you mentioned of the 7% versus some of the other quoted, it's like 1 to 2%?
Fluconazole's been around, I think got approved in 1989. The 150 milligram dose probably got approved around 1994, 1995. It's been around for a long time. It's being used, often it's being used indiscriminately, where patients just call, they tell their provider, I've got a yeast infection, they get a treatment, they might not even have a yeast infection at all. So there's been a lot of fluconazole use in general. And then for some people, it may be that if they get the maintenance course, after maintenance course, they start to get a resistant organism. Although I do want to emphasize though that with the patients that get maintenance therapy, with all the recurrences they're getting, they'd be getting a lot of antifungals no matter what, because the other choice is just to suffer in silence, which is not a great choice.
Definitely not.
Definitely.
And so you all looked at boric acid as an option, which boric acid has less strict guidelines, less strict like algorithms, and kind of varies in the treatment course and the doses and things like that. How did you counsel patients on using boric acid, or what recommendations did you come up with for the length of treatment?
So maybe I should emphasize that a lot of this was just made up. So we've been using boric acid for non-albicans yeast infections since I learned about it, again from Jack Sobel in 1992. For non-albicans yeast like Candida glabrata, it works about 70% of the time. For most patients, you give them a month, they get better. We felt that for a lot of the women with Candida albicans infections that were resistant to fluconazole, the issue is partly resistance, in which case we needed to change drugs, and partly recurrence, where we felt that if we treated them with a short course, they were probably going to recur anyway. And so we put them on boric acid. We bring them back 3 to 4 weeks after they started treatment, and then we tended to keep them on a longer course, often for up to 6 months. But it was a little bit individualized to what the patients were telling us.
And for those women that might be thinking about pregnancy or in that world, boric acid is commonly not recommended in pregnancy, or how did y'all counsel patients?
There are no data about boric acid use in pregnancy. I might add that with fluconazole, there are issues with using fluconazole in women trying to get pregnant. Increased risk of miscarriage, maybe an increased risk of having a baby with a heart defect. So all of our patients are told that they should be avoiding pregnancy, and that's also true with boric acid use.
And then how do you feel that your findings might change practice guidelines, or should they be incorporated? Do you think boric acid might need to be incorporated into an algorithm a little bit sooner, or reserved for those cases that are more in a resistant setting?
I think it's, so for Candida albicans infections, I think it's really the resistance setting. If somebody's pregnant or trying to get pregnant, they can use topical antifungals like clotrimazole or miconazole, which are perfectly safe to use in pregnancy. If they need to be on chronic therapy, we have them use an applicator once or twice a week of a 7-day topical. Works really well. So I think it's really the patients who come in on treatment and they still have a symptomatic yeast infection.
And any other things you want to make sure that we highlight from this topic, and any other information for those that might not be in a setting with like yours that is so familiar to seeing these?
Well, remember to do cultures. If you're not sure what to do, you can do susceptibility testing, although sometimes it's really difficult to get the labs to do susceptibility testing. And if you do susceptibility testing, often they'll do testing for drugs that don't even penetrate in the vagina. So just make sure that if you're going to use a different drug, that it's a drug that actually penetrates into the vagina. And then think of boric acid if nothing else works.
That's all the questions I had
Okay.
at this point. Is there anything else you want to make sure you answered so many of my questions? That's where we're going.
Okay, all right.
Well,
Excellent, thank you, Lauren.
thank you.